included that he had already received 8 injections anti-VEGF bevacizumab on monthly interval, and then history of 3 injections anti-VEGF ranibizumab. In the left eye, he had a history of 4 injections anti-VEGF bevacizumab. The systemic history included that he was non-diabetic and non-hypertensive, and there was drug history of tablet rifampicin since 1.5 years for 3 months. Family history was not significant. On examination, his vision was 618 in the right eye, and near vision was N8, and the left eye was 66 and N6. The rest of the anterior segment examination was normal. So the ophthalmic record that the patient had, on 3rd March 2020, he developed CSCR, which is quite prominent here. The central macular thickness of the right eye was 643. That of the left eye was 249, which is quite normal. Now here we can see the patient received 3 injections bevacizumab, and the follow-up was done after 4 months. And we can see that the CSR, the SRF, it's still there, and not much of improvement were there after 3 injections. So the central macular thickness was 643, and after 3 injections, his central macular thickness was 546. So still just 100 micrometer SRF resolved after 3 injections. So this is a picture of the left eye that the patient had, which is quite normal. Central macular thickness was normal, 250, almost in both the left eye. So after 8 months, on 18 November, when the patient came to us, not to us, but the ophthalmic record that the patient showed, his central macular thickness was 552 after 8 Western injections. Now this is of the left eye, which looks quite normal, but in the third picture, you can see that he's starting developing CSCR in the left eye. Here is quite prominent where he started developing CSCR in the left eye. So then he went on to receive 3 ranibizumab injections, and the follow-up was done after 11 months. His CSCR resolved, and central macular thickness was 224 in the right eye. And for the left eye, patient went on to have 3 injections bevacizumab, and after 3 months, his CSCR resolved in the left eye. This is a picture for the left eye. So after 9 months, patient came to us with vision 618 in the right eye and 66 in the left eye. So this was the picture when the patient came to us in December 2021. His central macular thickness was 435, and that of the left eye was normal. He was then lost to follow-up, then came back again after 3 months, and his central macular thickness is still, in fact, it has increased to 483 in the right eye. The left looks normal. So this was the fundus picture that we had. We can see that the macular reflex is altered, and the retina seems to be elevated at the posterior pole. Left eye looks normal. We went on to have an FFA being done. This is for the right eye, different stages: choroidal phase, arteriovenous phase. Now here we can observe that there is, along the superior vascular arcade, there's a leakage that is developing in different phases. This is a composite view that is increasing in size and intensity. In plot pattern can be seen. And this is for the left eye. This looks quite normal. So we went on to do right eye subthreshold laser, micropulse laser on the leakage areas. Power was 30 microwatts. Exposure was 10. 140 shots were being given, and the spot size was 100 micrometers. So just after a month, we repeated an OCT, and his central macular thickness decreased from 483 to 270 in just single setting of subthreshold laser. And for the left eye, that was normal. And then after a month again, it was allowed, the retina was allowed to resolve, the SRF was allowed to resolve on its own. And here you can observe that the central macular thickness further decreased to 172. But there's still the red flag area that is prominent here in the lower picture here. And unfortunately, after a month, the patient started developing recurrent CSCR in the left eye. So we went on to repeat the FFA for both the eyes. This is for the right eye. Different phases. You can see that there is a leakage area that is over here. It is increasing intensity and size. And for the left eye, different phases. So there is a leakage area here that is developing in the left eye. It is increasing intensity and size. So basically this was a reason why the patient developed CSR in the left eye. So we went on to do a right eye loading subthreshold laser. Power taken was 40 milliwatts, exposure was 10, spot size 100, and 15 shots was given to the right eye. And for the left eye, we did a subthreshold laser. Power was 40, exposure was 10, spot size 100 micrometers, and the shots, there were 22 being given. So we repeated an OCT after a month. And for the right eye, since we did a loading dose, so you can observe that the central macular thickness has decreased and there's still this red flag area is there. And for the left eye, it was 641. And when we went on to have a subthreshold laser, it decreased to 205. So you can appreciate that there is 400 micrometers of SRF resolved in just a single setting of subthreshold laser. So we did not go into the cycle of injections again, and we actually got the therapeutic benefits without producing any iatrogenic damage to the retina. So this is a recent OCT that we performed. So retina is stable. There is no SRF in both the eyes. So his visual acuity improved to 6.6 and N6 in the right eye. And the left eye was quite 6.6 as well, and N6 in the left eye. The rest of the anterior segment examination was normal. So ending my presentation with this hadith of Sahih Bukhari, which says, there is no disease that Allah has created except that He has also created its treatment. Thank you.
That's very nice. Just one pearl for the residents. If you want to memorize the indications of lasering the macula, just keep in mind you always laser a wet macula. There is no indication to laser a dry macula. So if you remember that, that will be putting less burden on your memory. Okay, so the next speaker is, okay, so it's Amir Awan. He will be talking about shifting paradigm of wet AMD management with Paginax. Is that how you pronounce it?
Paginax.
Okay.
That's right. Assalamu alaikum, everyone. So that's brief introduction and no financial disclosure. That's fine. Okay, so when we are managing wet AMD, the considerations are, so there are a lot of wet AMD patients, and if you look at greater than 50% of the eyes had residual fluid even after 2 years. So fluid still persists, and if the fluid persists, that means that the vision will remain poor. And greater than 50% injection in year 1 were given more often than every 8 weeks. So quite a frequent dose of injection is required, although we know that it's treat and extend. With Eylea we can go up till 8 weeks, but still it's quite a high number. And even in year 2, 44% were given more often than every 8 weeks. I think other problem which I think all over the world and we also face is adherence to the treatment. And if you look at that, up to 60% are non-adherent at 24 months follow-up. So which means that a lot of patients will not come for injection. If they won't come for the injection, fluid will come back again and it will remain there. They will develop a long-term damage. So 3 types of fluids very important when we are managing these patients. Fluid within the retina, which can cause damage to neurosensory functional deficiency, and it can lead to cystoid degeneration and subsequently visual loss. Fluid underneath the retina, either it can be subretinal fluid or sub-RP fluid, which also shows early sign of the disease. And we all know that, especially in the occult CNV, the leakage starts at the level of the choroid and then eventually it affects the retina as well. So it's very important to assess the fluid when you're managing the patient of wet AMD. So how Paginax is different from other molecules? Well, one thing is that it binds all isoforms of VEGF-A, which is really important. It's a small molecule, which means the quantity, if equivalent to aflibercept, it has got 12 times more molecules available. So it's more potent and more effective. There are a couple of trials which were initially done, Hawk and Harriet, on Paganex, and they were at 408 different sites, either in America, North, Central, South, Europe, Asia, Japan, and Australia, and that were properly IRB reviewed trials which were done. And what they found is that it gains robust vision with Paganex, and it outperformed aflibercept in achieving significantly fewer patients with intraretinal fluid or subretinal fluid at week 16 and 48, which is a significant thing. Another thing is that it dries faster. If you look at greater than 75% of the patients reach sustained dryness by week 32 and 20 by Paganex, and by week 56 and 52 with aflibercept in both Hawk and Harriet trial respectively. So quite significant difference. Fluid dryness is very quicker in case of Paganex. So another dosing phase, few patients on Paganex had disease activity in comparison to aflibercept. And significant number of patients maintained Q12 weekly injections after initial loading doses through week 48. So here, basically, the vision is shown in Hawk and Harriet trials, and you can see above is the Hawk, which 56% of the patients on Paganex, they were at 12 weeks injection after initial loading doses, and similarly Harriet around 51%, which is again a significant number. So initial loading doses, and then you can just move to 12 weekly injection. And when I talk about the loading doses, it's 3 monthly injection, and later you move to 12 weekly injection. And even if you look up to the longer term, up to 96 weeks, which means up till 2 years, you can see that that maintained at that level. So significant vision maintained if you compare with the aflibercept, but there are fewer injection in comparison to aflibercept. In that case, there were 5 monthly injection, and even later they were 8 weekly injection. So if you look at the superior fluid resolution, Paganex outperformed aflibercept in that case as well, and achieved fewer patients with intraretinal fluid and subretinal fluid at week 16 and 48. And you can notice the reference here. So both in Hawk and Harriet trial, you can see that a 35% difference, more percentage of fluid loss in comparison to aflibercept. Similarly, at 48 weeks, it maintained this activity. And even up till 96 weeks, you can see that there is a significant difference between aflibercept and Paganex, to 35 to 37% in both trials. If you look at the central subfield thickness, that again, aflibercept was compared with Paganex, and you can clearly see that Paganex was much superior fluid reduction, which is shown in the green here. And similarly, if you go up till week 48, you can see that it has maintained better reduction in thickness, and even up to 96 weeks. So other important thing to remember is in aflibercept, you are seeing the sawtooth pattern, which means that the fluid is coming and it's waxing and waning, coming and going. Whereas here in Paganex group, you can see the smooth, almost like a smooth level, so which means that the fluid is not coming back again, and patient is maintaining better vision. So typical pattern, what you get from starting from the baseline up till week 48. So here you can see intraretinal edema present there. Once after the loading doses, patient's central subfield thickness is reduced, no fluid, and that maintained up till 48 weeks and even up till 96 weeks. If you look at the sub-RP fluid, again, it showed better result in comparison to aflibercept at week 16 and 48. So both Hawk and Harriet trials showed 32% more reduction when compared to aflibercept in both trials. And similarly, at 48 week, it maintained similarly. And even at the 96 weeks, 26% more reduction. So it maintained for a longer duration, but as I mentioned, now injections are 12 weekly. So quite less number of injections in comparison to aflibercept. So it dries faster as well. That's another important thing. More fluid resolution you can get, which means absence of subretinal fluid, intraretinal fluid, or even sub-RPE fluid. And that's a Hawk data which is shown. So that clearly show that either at the start, week 4, week 8, week 12, and up till week 96, you can see that greater than 50% of patients achieved sustained retinal dryness by week 8 or 4 with Peganex, and by week 12 and 8. So it quickly dries up in comparison to the aflibercept. Similarly, in Harrier trial, that again showed similar pattern. You can see that the more dryness you can get with Peganex, as was shown in Hawk. And again, time to sustain dryness greater than 2 consecutive fluid-free pattern, which again is important. Sometimes what happens, as we were seeing in the sawtooth pattern, the patient were developing fluid again.